The following lecture is brought to you by the Bootcamp Subcommittee of the Committee on Resident Education of the Society of Neurological Surgeons. The objectives of this lecture are to learn about the following: the evaluation of stupor and coma, management of status epilepticus, evaluation and management of hypoxia, evaluation and management of sepsis, expanding posterior fossa masses, back pain and weakness after spine surgery, and cerebral vasospasm after subarachnoid hemorrhage. Here is case example number 1. You are called by an ICU nurse at 10 p.m. about a man who just underwent clipping of a right MCA ruptured aneurysm earlier today. He is still comatose over an hour after arrival from the PACU, but he was following commands when he left the OR. You ask for a CT scan. It will take about 10 to 15 minutes to disentangle yourself from the ED. The nurse reassures you that the patient is still mechanically ventilated from the OR and that the airway, breathing, and circulation are adequate. Per your sign-out sheet, the patient arrived earlier this morning as a Hunt-Hess grade 3, Fisher grade 3 with moderate hydrocephalus. He had a ventriculostomy drain placed, received 1 gram of phosphonatoin and 60 milligrams of nimodipine prior to going to the OR for surgical ligation. In your differential diagnosis, the possible causes of delayed awakening after intracranial surgery are numerous. Below is a list of potential conditions. You must consider all of these in the context of the specific patient and make a diagnosis. Red flags for neurologic compromise include a new asymmetry in the neuroexam and an exam not trending towards improvement. In this setting, you must be able to make a quick and focused neuroexam, including level of consciousness and arousability, motor responses and verbal output, eye function with ocular movements and pupillary light reflexes, and respiratory patterns with ABCs and breathing pattern recognition. Consciousness is a continuum. Level of consciousness in level of decreasing wakefulness are awake and alert, lethargic, obtunded, stuporous, and comatose. The causes of coma may be structural, with impairment of the ascending arousal systems of the brainstem, or bilateral cerebral hemispheric damage. It also may be secondary to metabolic derangement or toxic in nature. The Glasgow Coma Scale is a standardized grading scale to evaluate a patient's neurologic status. It has 3 categories: eyes, verbal, and motor. Here is a list of the differential diagnosis for coma broken down by etiology. Evaluation of a patient's pupils may aid in localizing the location of a lesion. Here is a diagram of the association between pupillary findings and anatomic correlation. Evaluation of a patient's respiratory status may also aid in localizing the location of a lesion. Here is a diagram of the association between respiratory pattern and anatomic correlation. Management of the comatose or neurologically deteriorating patient involves the standard ABCs, history, physical, equipment check, troubleshooting, imaging, and intervention. Here is case example number 2. You are called to the ICU to see a patient with a generalized tonic-clonic seizure activity. The patient is a 45-year-old female, status post uncomplicated resection of a right frontal meningioma. What do you do? Status epilepticus is a neurosurgical emergency. In general, seizures are hypersynchronous paroxysmal cortical discharges with either motor, sensory, or cognitive dysfunction. Status epilepticus is defined as a seizure lasting more than 30 minutes or more than 1 seizure without a return to neurologic baseline in between. Epilepsy is defined as the recurrence of unprovoked seizures. The etiologies of seizures are numerous. Common medical causes of seizures in the ICU are metabolic abnormalities, sepsis, and acute drug toxicity or withdrawal. Metabolic derangements such as hyponatremia, hypocalcemia, hypophosphatemia, uremia, and hypoglycemia may be responsible for up to 35% of seizures in critically ill patients. Patients with CNS insults are obviously at high risk for seizures. Highest risk factors include penetrating missile injury, acute subdural hemorrhage, depressed skull fracture, and cerebral contusions. Status epilepticus must be handled in an effective and timely manner. Here is a suggested timetable for the treatment of status epilepticus, showing a stepwise progression in therapeutic interventions. Benzodiazepines, dilantin, and barbiturates are used to treat status epilepticus. Here is a chart listing the IV doses, pharmacokinetics, and major toxicities. Which patients should get emergent EEGs? Patients who are in coma for unknown reasons. In this patient population, approximately 8 to 30% of patients will show some form of seizure activity. Patients being treated for status epilepticus who meet the following criteria: administration of long-acting neuromuscular paralytic agents, prolonged post-ictal period, have refractory status epilepticus, or have atypical features of their seizures suggestive of pseudoseizure. What else does this patient need? A head CT. Here is case example number 3. You are called to the bedside of a patient in the ICU who has had a sudden drop in her oxygen saturation. She is a 30-year-old female, hospital day 20, with the diagnosis of diffuse axonal injury. She has a ventriculostomy, is paralyzed and sedated, yet has ICPs in the high teens consistently. What are you thinking? The algorithm for working up and treating elevated ICP is complex, as illustrated in this chart. When managing these patients, one must quickly and effectively work through these paradigms. Hypoxia should be worked up with an ABG, chest X-ray, and EKG. One should also consider cardiac enzymes, a CBC, Dopplers, abdominal X-ray, and chest CT. Respiratory failure needs to be identified early. In this setting, classic indications for intubation and mechanical ventilation include respiratory criteria such as hypoxia, ventilatory failure, and tachypnea, respiratory distress. Neurologic criteria for intubation include decreased mental status and cranial nerve dysfunction, leading to aspiration risk. You must know the process in your hospital, remembering that a bag valve is a viable option until help arrives. Once the patient is intubated, the initial ventilatory settings must be set and an ABG must be done in 30 to 60 minutes. After the initial ABG, settings can be adjusted accordingly. Increasing rate, pressure support, and tidal volume will increase ventilation and decrease PCO2, while increasing FiO2 and PEEP will increase PO2. Here is case example number 4. You are called to the bedside of a critically ill patient with multiple injuries, which include DAI, pulmonary contusions, pelvic fracture, bilateral femur fractures, status post exploratory ciliotomy for ruptured abdominal viscus. The nurse is concerned because the patient, who is a 40-year-old male, looks septic. Define what this means and what are you going to do? Sepsis is a general term that covers a spectrum of conditions: systemic inflammatory response syndrome, multiple organ dysfunction syndrome, sepsis, SIRS plus infection, severe sepsis, sepsis plus multiple organ dysfunction syndrome, and septic shock, severe sepsis with hypotension. Sepsis may manifest with numerous signs and symptoms, Here is a list of possible findings in this patient population. The management of sepsis requires timely multi-system support as listed here. The main goals are to maintain oxygenation and perfusion to vital organs while treating the underlying etiology. Follow the principles of early goal-directed therapy, as there are internationally accepted guidelines, often protocolized within hospitals. These guidelines dictate diagnostic and therapeutic measures within the first 24 hours of recognized severe sepsis or septic shock. The diagnostic criteria for sepsis include infection, either documented or suspected, plus some of the following: fever, hypothermia, tachycardia, tachypnea, altered mental status, hyperglycemia, leukocytosis, leukopenia, arterial hypotension, hypoxemia, oliguria, ileus, thrombocytopenia, etc. In the first 6 hours of treatment, it is critical to begin resuscitation immediately in patients with hypotension or elevated serum lactate. Do not delay pending ICU admission. Fluid should be administered with goals of a central venous pressure of 8 to 12, mean arterial pressure of greater than or equal to 65, adequate urine output, and oxygen saturation of greater than or equal to 70%, or mixed venous O2 saturations of greater than or equal to 65%. If an adequate venous O2 sat is not achievable, then consider further fluid administration, or transfuse packed red blood cells to a hematocrit of greater than or equal to 30, and or start dobutamine infusion. Diagnostic studies include obtaining cultures before antimicrobial therapy. At least 2 blood cultures, including 1 peripherally and 1 from each vascular catheter that has been placed in the last 48 hours. Culture other sites as appropriate, for example, urine, sputum, CSF. Perform imaging studies, if safe and needed, to confirm or sample any other potential sites. IV antibiotics should be started as early as possible and always within the first hour of recognizing severe sepsis or septic shock. Broad spectrums include 1 or more agents active against likely bacterial, fungal pathogens with good penetration into the presumed source. Reassess daily to optimize efficacy, prevent resistance, avoid toxicity, and minimize costs. Consider combination therapy if Pseudomonas infection is suspected. Duration of therapy is typically 7 to 10 days, or longer if the patient is slow to respond, there is an undrainable foci, or if the patient is immunocompromised. Stop antimicrobial therapy if the cause is found to be non-infectious. Hemodynamic support involves administering fluids using colloid or crystalloid to a target CVP of greater than 8. Use a fluid challenge technique while associated with hemodynamic improvement. The rate of fluid administration should be decreased if cardiac filling pressures increase without concurrent hemodynamic improvement. Vasopressors may be used to maintain a MAP of greater than or equal to 65. Norepinephrine and dopamine through central venous access should be the initial vasopressors of choice. You may add vasopressin to norepinephrine. Use epinephrine as the first alternative agent if the blood pressure is poorly responsive. Do not use low-dose dopamine for renal protection. Patients requiring vasopressors should be monitored with an arterial catheter. Other supportive measures include ionotropic agents. Use dobutamine in patients with myocardial dysfunction. Steroids may be indicated. Consider intravenous hydrocortisone for adult septic shock when hypotension responds poorly to adequate fluid administration and vasopressors. ACTH stimulation test is no longer recommended. Do not use hydrocortisone to treat sepsis in the absence of shock unless warranted by an endocrine or corticosteroid history. Here is case example number 5. You were called to the PACU at 6:15 to see a 58-year-old woman who was 45 minutes post-op from a suboccipital craniectomy for resection of a cerebellar hemangioblastoma. She is having a headache, and the anesthesiologist wants you to evaluate her before escalating her pain regimen. While examining her, she quickly loses consciousness, and you notice she is apneic. You grab a nearby ambu bag and start masking. The anesthesiologist wants to intubate immediately, but you feel that the patient needs a ventriculostomy drain while she is being bag masked because you suspect increased intracranial pressure. Maybe her exam will return quickly if her CSF space is decompressed. Thus, potentially she will not need to be intubated. A heated discussion ensues, but you realize that you are going to be outnumbered in the PACU, so the patient is intubated while you gather EVD equipment. Once the ventriculostomy drain is placed, you take the patient immediately to the CAT scanner. CT scan confirms hemorrhage into the resection bed, which has caused compression of the fourth ventricle and acute hydrocephalus, now partially relieved by the ventriculostomy drain. The patient is emergently taken back to the OR for hematoma resection and has significant blood loss requiring several units of packed red blood cells and platelets. She returns from the OR with the ventriculostomy drain in place and is hemodynamically stable but remains intubated. Elevated ICP is the ultimate compartment syndrome. The Monroe-Kelly doctrine states that the skull is a fixed volume compartment filled with brain, blood, and CSF. The presence of a mass alters the homeostasis and by definition requires a decrement in one or more of these compartments to compensate and avoid an elevation in ICP. Elevated ICP may lead to several herniation syndromes as depicted in this image: subfalcine, central, uncal, and tonsillar. Bedside interventions for elevated ICP include the standard ABCs: elevating the head of the bed, keeping the head midline, hyperventilation with ambu bag, and osmotherapy with hypertonic saline and mannitol. Try to reverse the herniation or ICP spike and get the patient to CT scanner to look for reversible neurosurgical causes. Advanced bedside interventions include CSF diversion via ventriculostomy, hypothermia, and sedation. If an ICP monitor is in, consider vasopressors to support CPP unless intracerebral hemorrhage is on your differential diagnosis. One of the causes of elevated ICP and acute neurologic decompensation is an expanding posterior fossa mass. In this condition, management is determined by etiology. Ventriculostomy should be done with caution for possible upward herniation. Decompressive craniectomy may be done to decompress the posterior fossa and evacuate the mass. It is important to remember that patients with posterior fossa lesions may deteriorate quickly, yet can make a remarkable recovery if managed in a timely fashion. Here is case example number 6. You get called to the floor at 7:30 to see a patient because he is sleepy. He is a 76-year-old man who has just undergone an L2 to L5 laminectomy for spinal stenosis. You are walking to the patient's room and you are reading your sign-out sheet. History of hypertension and 90 pack years of tobacco smoking. He underwent laminectomy because of low back pain that was treated with NSAIDs. When you arrive, you find out from his nurse that he has received several doses of morphine, both in the PACU and on the floor, because he has been complaining of severe lancinating incisional pain post-operatively. The patient is difficult to arouse, but with stimulation will answer some simple questions and does seem oriented. He says his back and right leg hurt worse than before surgery. He says his legs feel numb. His motor strength is difficult to examine fully because of the effects of the pain medication, but he seems to be moving his arms with much more strength than his legs. He still has a Foley catheter in place since his surgery just ended a few hours earlier. You order a postoperative MRI after assessing airway, breathing, and circulation. MRI reveals a spinal epidural hematoma with compression of the dural sac. The patient is taken back to the OR emergently for decompression. Spinal epidural hematomas are usually asymptomatic. Risk factors include multi-level laminectomies, preoperative coagulopathies, and vascular anomalies, as well as preoperative NSAID use, intraoperative blood loss of more than 1 liter, age greater than 60 years old, those with Rh positive blood types, intraoperative hemoglobin levels less than 10, or an INR greater than 2 within the first 48 hours postoperatively. You should get an MRI to visualize the hematoma as soon as it is suspected. Early surgical exploration and evacuation gives the best chance for recovery. Here is case example number 7. A 59-year-old male with new onset focal weakness in his left upper extremity and decreased level of consciousness after ruptured MCA aneurysm clipping. The leading diagnosis in this case is vasospasm, a delayed narrowing of large capacitance arteries at the base of the brain. It is often associated with radiographic or cerebral blood flow evidence of diminished perfusion in the distal territory of the affected artery. Typical temporal course involves onset 3 to 5 days after the hemorrhage, with maximal narrowing at 5 to 14 days and gradual resolution over 2 to 4 weeks. Symptoms of vasospasm often start with acute or subacute encephalopathy. Focal neurologic deficits may follow, depending on which arteries are in spasm. Fever and leukocytosis may occur. You must rule out infection. Transcranial Dopplers are recommended for the diagnosis and monitoring of vasospasm, although cerebral angiography may be required for definitive diagnosis. Angiography also has the added benefit of potential treatment. The management of vasospasm includes oral nimodipine, early definitive treatment of the ruptured aneurysm, and in most cases, maintaining normal circulating blood volume to avoid hypovolemia. One approach to symptomatic vasospasm is hypertensive, hypervolemic, and hemodilutional therapy, or HHH therapy. Cerebral angiography and/or selective intra-arterial vasodilator administration therapy may be reasonable after or together with or in place of HHH therapy, depending on the clinical scenario. Consider angiogram for angioplasty if there is a focal deficit. HHH therapy involves hypervolemia with a target CVP of 8 to 12, hypertension with systolic blood pressures up to 180 to 220, and hemodilutional therapy with a target crit of 33. Now back to our case example. The clinical diagnosis of vasospasm is made. The patient is already on nimodipine. You bolus 1 liter of normal saline and increase the IV fluid rate. Use vasopressors to increase MAP goal to 100 to 120. Notify the interventional neuroradiology team, especially if your efforts above do not quickly reverse the focal neurologic deficit, and consider cerebral angioplasty. Remember, symptomatic vasospasm is a neurosurgical emergency and requires rapid intervention, escalating medical management until symptoms resolve. Initiate angiography in a timely fashion if medically refractory.